Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine. And silver level sponsor, Hanger Clinic. Everyone, we're so excited to have you with us for the final night of the 2020 online conference. Tonight's session is titled Current and Future Role of Occupational Therapy Services in Acute Care. Our speakers this evening include Elizabeth Burch. She graduated from Brunel University with a master's in OTD. She's been working for 6 years in the acute care setting. We also have Leslie Murray, who graduated from Mercer University with a degree in biology and special education in 1986. She graduated from TWU with a master's in occupational therapy in 1988, and she's been working as an occupational therapist for 31 years. She has experience in acute care, inpatient rehab, outpatient, subacute rehab, and acute care hospital setting. Finally, we have Lisa Smith. Lisa graduated with a BS in physical therapy from Georgia State University, a master's in education from the University of New Orleans, a doctorate of physical therapy from Alabama State University, and has over 32 years of acute care and subacute care rehab experience. Welcome to tonight's session, and I'm going to hand it over to our speakers.
Thank you, Kristen. Thank you for moderating for us. Just to kind of let everyone know, what we're going to kind of do is we'll have the chat going, but we plan on leaving enough time at the end for some questions, and that way we can have a little more of a dialogue. So definitely, as you're thinking of them, put them in the chat and we'll get to them, okay? So... Here we go. All right, to kind of identify our learning objectives for tonight, we are going to define the role of occupational therapy in the acute care setting. We're going to identify how we need to have those critical reasoning skills by the occupational therapist for the best care practice. We're going to look at some current evidence that support the need for OT services. And also we're going to look at how really OT services can help decrease the length of stay in the hospital and help reduce the readmission rates. We also want to talk about how occupational therapy can help with other specialties within the hospital setting. To kind of introduce a little bit, we work at Piedmont Fayette Hospital, and as you can see, our purpose, our promise we make to our patient is to make a positive difference in every life we touch. We are a 282-bed hospital. We are one of 11 in the Piedmont healthcare system in Georgia as a nonprofit hospital. Currently, in the past 22 years since we've been with, we were originally Fayette Hospital, but now with Piedmont Fayette Hospital. We started out originally with just one full-time OT who was inpatient and outpatient. And in those 22 years, we have grown quite a bit, as you can see, between inpatient and outpatient with the number of staff we have. So let's just go ahead and get into it. So pretty much, what is our key role as occupational therapists in the acute setting? We have to identify the changes with our patient to make sure they're medically stable to even participate in therapy. We look at the overall well-being of our patients, which can be very different depending on the patient with their prior level of function versus their current level of function, and where we can kind of predict where they might be able to go. As occupational therapists, we are going to use various approaches to evaluate our patients with that current level of function. In the acute setting, we are mostly looking at those activities of daily living, and also now, as it's described in framework, the BADLs, basic activity daily livings too. We can get a little bit into those IADLs also, depending on the time the person is in the hospital setting with us. And then we also do look at functional ability, making sure the person can get to point A to point B as needed. So in the acute care setting, as most of y'all have kind of looked in the research has found, people do not stay in the hospital very long at all at this point. Typical length of stay is anywhere from 1 to 5 days. So really we have to, as soon as a patient's stable, to get in there to evaluate, to figure out where this person needs to go. What is the safest discharge? We look at their abilities to complete these ADLs, IADLs, and mobilities. What we are seeing is some of the major barriers for someone to be able to go home is the concerns with falls and their decreased independence. Recently, there has been an article that shows directly the occupational therapy services can directly show the reduction in hospital readmissions. And honestly, as I pulled out from the key articles, that we're finding out what the patient can do sooner, and we're not sending them home before they are ready, regarding being able to point blank talk about their ADLs, their mobility with the discharge planning that we provide assistance with. One of the key aspects that occupational therapists are involved in now is the benefits of early mobility, directly working with patients in the ICU, especially as therapists, we can help decrease the time they're on that mechanical vent. We can definitely help with the delirium, with getting some sensory integration going on, helping with schedules, and then also looking at their muscle strength by getting them moving sooner. One key percent that came from this article, that typically there's a chance of 3 to 11% loss of body weight while in the ICU. Oh, I read that wrong completely. There. Oh, there you go. There you go. 3 to 11% of strength per day while in the ICU.
And then 18% loss of body weight.
And 18% loss of body weight. All right. So kind of as an occupational therapist, one, I think the key thing is our clinical reasoning skills. As we know, we're there to plan, direct, and perform and reflect on the patient's care. We do look at this from a kind of a different lens because we're looking at the person as a whole. I feel some of the key frames of references that we use in the acute care setting is the biomechanical frame of reference, rehabilitation frame of reference, MOHO, the model of human occupational performance, and the PEO, the person, environment, occupation. Okay, so a typical evaluation in the acute care setting obviously will depend on the level of care the patient has, if they're in, say, ICU versus a medical floor. But typically all our evaluations are going to be looking at the key things of prior level of function, the home environment, looking at the current level of function. We do spend most time looking at our upper extremity with the range of motion with manual muscle testing. For example, if it's a stroke, looking at their coordination or dexterity. We have found the best evidence-based practice is having 2 standardized tests. The 2 that we use quite a bit are the AMPAC, to look at the performance of ADLs. It is a quick standardized assessment with 6 questions. It is easy to score and it has great outcome. You'll actually hear quite a bit about the AMPAC in the next section if you attend. And then we use the modifier ranking scale because there's the pre-morbid and the current. So we can really show the justification between what they were doing before and what they're doing now. When we're looking at discharge planning, I've outlined some of the key that we will refer to, which might be a person to go home, might be going home with home health services. Acute rehab, which is typically a short stay, anywhere from 7 to 14 days, more intense therapy up to 3 hours a day, versus the subacute rehab option, which might be longer, up to 20 days typically is what Medicare will pay. And then also potentially outpatient services. So this slide shows a basic evaluation form that we created to kind of help guide our clinical thinking while we're in there, to kind of help us just be able to make sure we're asking the correct questions. And also when we go back to our notes, we have a key thing to look at. So that way I found it being especially helpful with realizing what equipment a patient might already have and what they might potentially need. So we have a video, and I'll actually play it about twice because it's very short.
Mm-hmm.
And the thing that I want everyone to kind of think about is like, what do you notice is going on in the video, just using your observation skills?
Walk faster.
She was so cute.
Alright, hold on a second. Go ahead and stop here. I feel like we're going to stop. There you go.
I'll play it one more time.
Walk faster. Alright, hold on a second. Go ahead and stop here. I feel like we're going to stop. There you go.
Okay, you want to start it? Okay. This video is a patient that was in our ICU, obviously intubated. Just to let you know what some of the stuff is. Austin, the gentleman in the black scrubs, he's one of the PTs. And then the patient, and there's a respiratory therapist in the greenish color. And then in the blue was one of the nurses. And in her hand is the portable vent. And well, some of the telemetry box. And then in the respiratory therapist, this one is in the green, has the little portable vent that we use to mobilize patients. And so that's all of the items that you see in that picture. You can see her ET tube. This patient was super alert, super awake, obviously oriented, following commands, very mobile, and she actually got extubated the next day. So we just wanted to show you that video of a patient being mobilized on the vent, and how most people think, oh, you can't mobilize somebody that's on the vent, but clearly you can, and it helped her tremendously with her pulmonary status, and she got extubated the next day.
Mm-hmm.
So in the hospital setting, there's a lot of medical information that you have to be aware of, especially in ICU, the lab values, the vital signs, line management. Some of the things that you may see are chest tubes, the IVs, the Foley catheter, the central line, the NG tube if they're on the vent, and some of the drains after their post-op surgery, hemodialysis support, and then the different kind of oxygen from the nasal cannula in the vent or the trach. And then through COVID, we learned a lot more about high flow and BiPAP and things like that. I'll go into that later. Assessing their pain. Skin assessment is huge, because pain and skin assessment are huge because they're immobilized for so long. They have back pain. They're immobilized, buttocks pain, their skin assessment, breakdown on their heels, their buttocks, elbows. So we have to do a lot of assessment with that. And then the surgical precautions, if someone has abdominal surgery or a new trach, things like that, we have to know of all those precautions. So the medical information that you learn in a hospital setting, in addition to all the OT or PT information that you know from going to school, is you learn just so much more. We are exposed to the pulmonologist, the hospitalist, the nephrologist, the neurologist, the cardiologist. We go to rounds in all the floors. So we're exposed to lots of different consulting services. So we get to learn a lot about all those different services, in addition to regular OTPT type stuff in rehab settings. Okay, we took that one out. Okay, since this is, the hot topic of the year, we wanted to talk about this a lot because in our acute care hospitals, we saw a lot of COVIDs here at Piedmont Fayette. March 9th was our first one that came in, and we have had them ever since. So we've learned a lot through it. They come in with their usual symptoms of shortness of breath, a cough, a loss of taste and smell, a fever. Some of them have the nausea or diarrhea. They are brought in. Obviously, the goal is to get them stabilized and home as quick as possible. But we did have a lot that came in very, very sick. And I will say from our experience, most of them had a lot of comorbidities with obesity, diabetes, hypertension, smokers. So they typically deteriorated quickly. They came in, say, with shortness of breath. They were put on a nasal cannula. Their O2 sats remained low. Then they went to high flow. They went to BiPAP, and then they had to be intubated. So when they come to ICU, they're intubated, sedated, stabilized. And then as soon as we could get in there within our parameters, we have certain parameters that we're allowed to go in and start seeing our vented patients. We tried to start mobilizing them, waking them up, get them off sedation, and mobilize them, because when you're on the vent, even if it's just a few days and you are unable to move for 2 or 3 days, the amount of strength that you lose is just unbelievable with your mobility and just your activity tolerance and the delirium that comes along with that when you're sedated and all these tubes and tunnels, and you wake up and all these strange people are kind of hovering over you. And then some of the people that are prolonged illness, a lot of psychosocial learned helplessness type behavior also comes along with that. Now, we check on all the patients in ICU. When they start meeting our parameters, we start to see them. Now, we learned a lot with COVID and the proning position, and we've included some information about that later. They prone them and flip them to different positions: prone, right side lying, left side lying, supine, to help with the fluid buildup in their lungs. And hopefully that did prove throughout the country. I think you kept hearing it on the news about the patients being prone, and they would progress a little bit quicker. Even if we can't mobilize, we start with upper extremity exercises. And then, of course, later on, I'll go over this, the energy conservation that they have to practice, because every activity they require a rest break. Our motto around here is mobility is medicine. The rehab services we included with all our patients are PT, OT, speech, diabetes education. And we created this home exercise program for our COVID patients. I think, is it included on the next one? Mm-hmm. Yeah. Okay. So the next slides, you will see the HEP that we created, and we gave it to all our COVID patients, no matter what level they were on. So we'll go through that one. Mm-hmm. This is a picture of the proning and why we did it. We had to explain it to the families. Families weren't coming in at that time, so we helped them. We FaceTimed a lot. We talked to them on the phone a lot and helped them understand what was going on with their family member. Proning is scary. It scares them to know that their family members have all these tubes on, they're being flipped and mobilized like that. But it really helps the ventilation and oxygenation during their recovery. So that was and we give this to them to help them understand. And then the next one is the sideline positions. So they would go from prone to right sideline to supine to left sideline. Exercises, we've really had to focus a lot on the upper extremity, lower extremity exercises with these patients. And I will say we did learn a lot about this also with prolonged hospitalization, intubation, and proning. They had a lot of shoulder arm weakness. So immediately we tried to get them doing upper extremity exercises. active assistive, active range of motion. But we also found with proning, when you're proned, you are laying like this, and then you flip and you lay like this. So that's how we do it. But a lot of people came out with shoulder pain, especially if they were obese. They had a lot of shoulder pain with weight, and then we had all sorts of skin protection all over them. Some of them got skin breakdowns on their shoulder as well. But they all came out with profound weakness in their upper extremities. Okay. Of course, once they're extubated, and when they got extubated, they would go to our step down unit, and then they might be on like the high flow nasal cannula, which is oxygen. It looks kind of like a nasal cannula. It just allows more than like 6 liters of oxygen. And then if they got below 6 liters of oxygen, they could go to our other 2 floors that were designated for COVID. They were on 6 liters or less on a regular nasal cannula. Energy conservation was huge. When we got to see these patients, let me back up one step. If you're on high flow in the intermediate care unit, typically our parameters were 60%, but our pulmonologists really encourage us to get in there and start seeing them, even if they were at 80. The typical presentation of these patients, their heart rate would go way up. So we had to give tons of rest breaks, but it was kind of a catch-22. You didn't want them laying there on the high flow, because then they were at high risk for being put back on BiPAP and then being back on the vent. We wanted to mobilize them, even if it was just sitting on the edge of the bed. Let them sit there for 5 minutes, educate them on energy conservation, maybe stand, maybe sidestep, and if maybe get to a bedside commode, maybe do a few arm exercises, but lots and lots of rest breaks with these patients. And we found that if we did that, we could see those patients on the high flow, even if it was above that 60% parameter. Our pulmonologist really encouraged us to do that. So there's a lot of information about the energy conservation, the household safety, and the bathroom safety. Mobility is medicine. There's a few of the PT exercises that they did with them, and everybody got this pamphlet and went home with it. There's some of the speech and swallowing. Of course, after you're extubated, you have to go through a swallowing assessment to make sure you're safe. You know, those are muscles too. You get very weak when you are intubated for prolonged time. So those are the exercises they did with their swallowing.
And this is also too where we really had to do a lot of education of the importance of out of bed. I think all of us really understand the importance when we can get to that 90 degrees sitting up in a chair, the difference it can make. So even sometimes if we had to coordinate, definitely if we knew speech really wanted to get in, a PT session will try to be before or after. And if it's someone that the speech therapist felt really would benefit, even if they could only tolerate being upright for the 30 minutes after they would eat, we would make a point of getting all 3 discipline in there in that time frame. So it was what was best for our patient. With some of those individuals that were with us 20, 25 days, like we really got to know those guys and kind of realize what they needed from us from this aspect.
Yeah, I mean, most of these folks that were intubated, this is all when COVID first started, of course, they typically would have gone to acute rehab or subacute rehab. But when this all started, those facilities weren't taking these patients. So we were their rehab. They would stay with us from ICU to intermediate care and then up to our other 2 floors. And that was kind of our rehab floor that we were doing with them, because they weren't being accepted into rehab facilities initially. And then these are some basic nutrition guides so we came up with this packet and gave it to everybody. This is a case study of someone that came into our facility, and we all got to see him. Typical, the weakness, fever, cough, chills. He tested positive. And when he came in, he was that desatting that much that he required the high flow nasal cannula immediately. He came in on the 23rd, he was on high flow. And then by the 27th, he was declining. He had to be put on the BiPAP. And then on the 28th, he was declining, had to be intubated. He was paralyzed, sedated. And those are the settings that we had him on: 100%, PEPA 14, and he was proned. On the May 2nd, his settings were improving. And then by May 4th, he got extubated. They ruled out any PEs. On the 9th, he was transferred out of ICU to the intermediate care unit and down to 3 liters on oxygen. We stepped in and saw him. I've got our OT eval here on the 6th. Gave him an AMPAC score of 15, which you'll see in the next presentation. 24 is the highest, like 24 out of 24, you're independent. We gave him a 15. We were thinking he needed to go to acute rehab. PT and OT saw him a few times before he left. He ended up leaving on the 10th, being discharged, and then he went home on 2 liters of oxygen, and then he started outpatient therapy and went to outpatient physical therapy at that point for about a month. But he was discharged home with a rolling walker and ended up doing really well. So he was a success case that we had. And there was just some of the outpatient goals that they set. He started and stayed a little over a month and did really, really well. So that was a good ending. And some of ours, you know, we have a ton of cases that we could go through, but this is one that kind of went through the whole intubated, step down unit, regular floor, and then back to outpatient.
And it took 3 months for this person who was a fully independent adult, working, driving, completely independent. And it just shows you how quickly, once he did catch COVID, he started deteriorating to the point where obviously he wasn't breathing on his own and his body in essence was shutting down. So because of what we've learned throughout this was kind of still early on when he first got admitted. And looking back at it, we've been kind of seeing, you know, being able to compare it to other patients, like this would be ideal state, someone to make this kind of recovery, because once he really started stabilizing, he really didn't have any major setbacks where he had to go back on the vent or develop that PE, where in some of our other cases, it's been more of a cause and effect, especially with the PEs. Very common we were seeing in our COVID patients. Unfortunately, I would say most of them were in that obese state. And honestly, immobility really was a major factor in some of these other things that started after they developed COVID.
Right. And he was only 47, so he had that on his side, and he was obese and had diabetes and hypertension, but totally independent prior to admission. And even in the days that we saw him, when PT and OT first stepped in, when he met the parameters and we could see him, his AMPAC was the 15 out of 24, which is usually someone that needs acute rehab after that. But by the time he left a few days later, he was already at 20 and 21 AMPAC score out of 24. So he was progressing towards needing outpatient. So he did, and he went to outpatient. So we had to change the discharge plan, which is a good thing. And he went to home and then went to outpatient therapy. So he was a great success story. And a couple other case studies, we had more typical hospital case studies. The low complexity would be more of a ground level fall with a total hip replacement, kind of your typical thing. You know, we all know now that the knee and hip replacements are changing. The elective ones go home, day of surgery, they're shooting for. But the falls, the senior citizen type patient that falls and breaks a hip, they are admitted. They have to get stabilized, cleared by cardiology, and then have their hip replacement. PT and OT get them up, day of surgery, see them for a few days. Typically, those type patients that fall, the seniors that may fall, they go to rehab. Some of them will hopefully go home, but most of those have to go to rehab. Now, this is a patient that I had, and Lisa, the next speaker, and I had, she was on the vent, COPD, lifelong smoker, ended up having to have a trach. And this first picture on the left is her getting up and she's in our Maxi Move is what it call it, the brand that we use, the R.J. Huntley brand, but we get her up and transfer her because she was just profoundly weak. And we're lifting her up like the Hoyer lift, and she's on the bedside commode. So with this lift, I can lift her up. And the thing about this sling, that why we like it, is it doesn't go all the way underneath your bottom. It lands at the top of your bottom, so you can, it's open underneath and you can actually sit on the bedside commode. So the middle picture, you can see it from the side and she's sitting on the bedside commode. We never have to unhook her to anything, and she feels safe, she feels stable, and she could use the bedside commode and use the restroom. Now the next picture is her on another piece of our equipment. We love this. This is called the Steady. It's a sit to stand, someone that can stand with maybe min assist, but they're not quite ready to pivot and they're still weak, but doing sit to stand with this obviously increases their low extremity strength. And then hopefully the next goal would be using the walker. And she's still has a trach still at this point. So she was a great patient that PT and OT worked with a long time on, and then ended up going to LTAC to try to get off the vent after her stay with us. So that's another example of being able to see all those patients that are medically complex with all the tubes, tunnels, and lines, but you can still mobilize them. You can see her, she's awake and alert and ready to participate.
We included this slide, and Tiffany will have this posted for the resources. I think honestly, when I started in the acute care as a new grad, I honestly had no idea the importance of mobilizing patients. I feel like I got a brief overview in school, but I think as I've continued in the acute setting, realizing how much really is affected by just staying in the bed one day, and how directly when you're not moving, how it affects every system in your body. This mobilization really breaks it down. I think even be great for students to kind of understand, like, this is what's going on in your body as you're supine.
Mhm.
This is what happens when you're sitting up. I know one of the great examples is digestion in there. So that was one resource that I felt was very, very important when I started as a new grad. I bet most of y'all are familiar with the OT toolkit. We use this quite a bit. We felt very passionate. We were able to purchase the license so we can give it out to our patients. And what's been nice with that, there is the English version and the Spanish version. We do see this quite a bit with the language barrier, but there's some awesome pictures in the toolkit, and we can definitely relate it to what's important to that person wanting to be able to do. The toolkit also, we use it not even just in the hospital, but also as a great resource with outpatient. So I think sometimes, I'm sure as most of us therapists know, you can educate someone verbally over and over, but it takes a visual picture to really click. This third website is an amazing website that talks about all the different standardized assessments out there, talks about even the frames of reference, the so what aspect. I cannot stress, this is one of my favorite sites. With being a clinical instructor, I go to this one often with my students.
Mm-hmm.
It is a wonderful resource. Here's our references, and I will stop sharing at this point.
Oh, hello.
And then,
Is there any questions on here?
You guys look good. I guess one of the questions that I have, do you want us to open up with just case questions, or did you have a preference for what kind to start with?
Anything. I see one that brachial plexus issues. Someone wrote, oh, we have had a lot of brachial issues with our patients that were prone for long periods of time. Huge. We actually have one gentleman that we're talking to that came to us. He was severe, prone, everything, intubated, long haul, stayed with us, ended up going to LTAC, ended up then going to acute rehab. Now he's back at home, and we're hearing that he's doing well from friends of friends that know him. And he ended up having residual deficits in that arm from the proning position. There's so much, I mean, we have learned so much with COVID, and have gotten, so much information of what to do with these patients, because it just, came hard and fast. And immediately we kept saying, we want to get in there. We want to get in there. We want to mobilize these patients. Because initially everybody was like, no, the less people in there, the better. And we all knew that when someone's immobilized this long, we've got to get PT and OT in there.
Can you talk a little bit about that time frame, like from the time that you all had the first patients, or even was your hospital, did you have a specific unit and then it expanded as the population did? And
Yeah,
how did they triage the, who initially, and then, how did they
Right.
open it up?
Well, the ED came up with a system to isolate them all. And then when they came in, they were all going to ICU. And initially, we saw, can you remember how long? I mean, we were knocking, we were knocking on the door wanting to get in there. Rehab was, because we all know, I mean, we've got some great therapists that know how important mobility is to anyone that is critically ill,
So really, when someone's coming through the ED,
How
how
long was
quickly did before we could get in there from a therapy standpoint when they were
how
coming through the
long were
ICU?
Remember they were saying, no, we didn't want any rehab in there yet. How many weeks was it then they finally, the pulmonologists were like, you know what, we need to get in there and get rehab in there.
When COVID first happened.
Yeah.
In the ED.
Yeah.
Mhm.
Our first patient came March 9th. And I would say we were seeing patients in April by April.
Yeah,
I mean, it wasn't long
about a
because we
month.
were still going to rounds and hearing about these patients. We're like, we got to get in there and mobilize these patients. They were, their settings were improving. They were getting better and better. So we were kind of hounding about getting in there and helping them.
And I think too with it is because I think we've all heard in the news the worry about PPE and what was deemed essential for people to go in there. And then honestly, it was advocating the role of rehab. And I think Leslie was kind of touching on that. Like we had to show like why we were important. And then, and I see that Elizabeth actually wrote this about being on the proning team.
Yeah, we did.
This was something I know, obviously being newer in my career, I've never experienced anything like this. And then even talking to the veterans therapist, like coming up with a plan, because we honestly, when this hit, we didn't know what was going to happen. And so I'll say our administration did a very good job coming up with a plan, and we got put in teams. But honestly, I had never really had a prone anyone in my life. And then when rehab was deemed the experts on this, and I'm like, I don't know what I'm doing. So they actually had to train a lot of us on how to even prone someone successfully. So one, the patient is safe, but also the people who are proning. And so we actually kind of use the burrito method, try to have at least 3 people on the side if we could. But when you're trying to coordinate 7 people and you have that PPE on, you don't want to sit there and ask questions. You want to get in and out. Because I don't know how many of y'all have actually had to wear the PPE, but it's hot. Like, I mean, and y'all can imagine, being in a room 20, 30 minutes wearing all of that. So that was a big learning curve.
It was a lot. Our ICU was a year ago, our ICU was 14 beds. Then we moved to another floor. And now our ICU, the critical times was 30 beds. So we had a lot of people on the vent. We had a lot of people that we were proning. So rehab was helping with that. Just, we would go from room to room and prone them. And you're right, 3 people on each side, the respiratory therapist and the nurse would be the caller. And we did that burrito roll because we had already transitioned in our ICU out of using the prone beds, the big, huge proning beds that you see. We were already doing the burrito rolling and proning people pre-COVID. So some of us were familiar with it, but a lot of staff weren't. So that was also part of our role in the ICU.
Then I know a question that kind of came up was how kind of we figured out we were going to do like COVID versus non-COVID patients. So kind of to explain how we as therapists would set up our schedules. Everyone did see COVID patients. Obviously, we had a few exceptions, mainly if someone was pregnant. We did not, that point, we only had 1 OT that was pregnant. She did not go into COVID rooms. But we would also have COVID patients and the non-COVID patients. So the way we would try to set it up is see all of our non-COVID patients first, then try to see our COVID. But then when our numbers got so high, we did mostly have COVID at some points, depending on your floor. So we would rotate those floors to kind of spread it out. Because I can honestly say, starting with the COVID patients from start to finish, it does affect you as a person. It's hard not to take the personal aspect. One, we talked about the PPE, but also what it does to you emotionally, seeing these patients and they can't have their families. luckily we did have like the iPads and we could start FaceTiming. But a lot of times, you know, it's just like you become that person's family, especially when these people are there with us, you know, 2 to 3 weeks. That's something you would not see, but you really be able to develop those people. And then when you come in one day and that person's passed away, it's very hard emotionally to handle. So definitely leaning on each other was like the key thing that we've learned, and to have those outlets, and also realizing burnout was a real thing between our staff. So we kind of had to work together as a team to kind of help that, to try to, you know, keep our patients safe, but also keeping our team safe as possible too.
I mean, it's, you know, you always think, you know, I've been doing this so long, I think I can't learn anything else new, you know, after a while. But in acute care, you learn something every day with medical stuff that you're learning that you're maybe not exposed to in different settings. And that's why if you're a person that likes that type of stuff, that you learn so much more outside of PT, OT, speech, rehabs. You know, you learn all these different consulting services and things that I would probably have never learned outside of that if I were, you know, in an outpatient clinic or something, maybe, I don't know. But it's what we have learned medically from this COVID experience, medically and in rehab and emotionally. I mean, we saw a lot of folks that passed away. We got a lot attached to a lot of the patients that were there a long time because, like I said, they couldn't go to rehab. And we watched them progress. I mean, standing in that steady that I showed you, you know, our windows, you can't see in, but families couldn't come in and they'd be parked in the parking lot. And I would roll their family member up to the window. They couldn't see their patient, but the patient could see their family members parked out in the parking lot to wave to them, you know. And then I'd have a therapist run down there with her cell phone and call me on my cell phone. So then we could talk to, you know, it's just been an unbelievable experience and year and what we have learned in the hospital setting. And I know, you know, they've progressed finally to the rehab settings, which has been all in outpatient settings now. So it's been awesome, the amount of things we have learned in a short period of time. Yeah.
Is there any other questions anyone has for us?
Did I hear something? No.
When you had your patients, after they were able to follow directions more, when they were in the prone position, what types of strengthening activities or what type of, you know, pre-functional tasks did you have them do?
Well, in proning, you're sedated. So it wasn't until once they were out of that critical stage when they're prone, then they are supine and they can start mobilizing, even intubated. We can do bed exercises. We can do rolling. We can try to sit them on the edge of the bed. The profound weakness. So it was very minimal ADLs at that point. We would coordinate with PT, even just to get them sitting in the chair with the lift. Like, say I would go in first, maybe see if I could sit them on the edge of the bed, maybe do a little bit of arm exercises, maybe see if they could just hold a washcloth to put some warm water on their face, anything like that to get them feeling human again. Maybe a little bit of a sponge bath on the upper body, and then get them to the chair. I'd text PT and say, okay, Mrs. So-and-so is up in the chair. It's 9 o'clock. You know, she'll probably tolerate, you know, an hour or whatever. And then PT would coordinate coming in, doing their exercises, and then help get her back to bed. It was, I mean, you're talking about really small goals, really small goals at first.
And do you limit the proning to just the severe due to the amount of time it takes to prone, or just because you think that the benefits of other therapeutic interventions at that point outweigh using that time that you have for proning? Or is it something the nursing team can handle at that
That's
point?
the pulmonologist. Yeah, the pulmonologist determines how long that goes on, like how many times, how many days, that kind of thing. That goes along with all the parameters that they look at. Because when you're that severe and you're on 100% FiO2, people 14 or whatever the settings, you're maxed out. You might be on a lot of pressure support, you know, that kind of stuff. So you're sedated, paralyzed, we call it, and they're not aware of anything going on. Now, the nurses do the range of motion as best they can. and do the skin barrier protection and all. I mean, we had these patients with these little Mepilex skin protectors everywhere we could find. We were trying to protect their skin. So as soon as they were recovering, showing improvement, and they could come back and be flipped and be supine and then meeting our parameters, we came in as soon as possible.
But we also saw people too, we had to educate on self-proning too. So those severe
that's right.
cases after they're at the road of recovering, but even some of those not as critically ill, like like Leslie said, we ended up having 2 floors dedicated to COVID patients. A lot of times it was our physicians would still continue to order it, but I feel like I had to explain more the purpose and why they needed a prone. So sometimes it was just even helping someone motor plan. How do you do it yourself? I mean, I don't know if most of y'all have ever been in a hospital bed, but we're looking at a twin bed. You don't have a lot of room to move around. And then we've kind of had to figure out too with wound care, some of our specialty beds, like some of those you don't really have the room to move. So we've had to coordinate with our equipment how to really just even turn the patients. So I feel like there's more education that we were involved in too within the whole system wide with the proning. So yes, we in the packet too, even like when the patient left the hospital, they were still encouraged to prone at home as much as they could. Throughout that way, they were making sure that fluid doesn't build back up in that lungs too, to help them continue as they keep recovering.
Yeah, patients never, they don't understand proning. You know, we all know as you age, not too many people lay on their stomach very often. It's great for you, great exercise for you as well, but not too many people. Then you throw in somebody that's obese, sleep apnea, all that kind of stuff, and try to get them to prone. So when they were on the other floors, we would have to encourage them to prone. Some were really good at it and some would do it. Some were like, you know, they didn't remember that they were prone in ICU and they were like, no, I can't do that. So we really had to show them the benefits of it.
Did you see any profound ICU delirium or CCI or any? Okay. And then what type of like role did OT in your facility have to help with that? And any interventions you found helpful?
Yeah, I mean, there was constant orientation. These people, when they started waking up, they were hallucinating. I mean, all the medications that were going in them. And then you talk about people with a comorbidity list of, you know, a mile long. So it took forever for them to filter out all this medication and everything they were on, and their day nights were messed up. We were constantly orienting. We were constantly trying to keep them awake during the day, lights on, windows, blinds up, orient them to their place, what had gone, how many days, the passage of time. They don't realize how many days they had been there. Anything that had happened in the news, you know, they had missed. So we were providing orientation, but that was a big hit with those folks.
And even too, like how the rooms are kind of set up, they're all kind of individualized to an extent, but families were allowed to drop personal items off at the front and they were taken up to the patient's room. For example, one patient that comes to mind, his family had did a big display board of their family members. And so at first, I know the patient I was working with, he couldn't remember his family members, like he would recognize them. So that actually did a way for me to help with the cognition. And then that to see him kind of progress, remembering his family, these stories. So that's where kind of with the iPad, getting the wife involved. So that way, you know, she was also, because it was the first time they've really ever been apart. So that kind of helped that with relationship too. And I think that really, him hearing her voice made a huge difference. And I think with some of the nursing staff, when they were seeing me do this, there was that aha moment for them too. So that way they can talk, because even like the older population, they do not really understand Skype and Zoom. And so there was a big learning curve for a lot of our patients. A lot of our patients still had the flip phones to begin with. So Piedmont did a great job when we said we needed more iPads, because literally we had to figure out how can we take the iPad in the room? How can we protect it, but still wipe it off? I know, Kristen, technology is a big thing for you, so you completely know where I'm going, but that's also a way I feel like is a difference in a generation where we are now. Technology is so important, and that's something different than Leslie would have had 20 years ago. That's sorry, wouldn't have been included in OT. So like we could write goals regarding technology in that way too. And I think that's something that I would really take back to people to show how it really made a difference. And I think that your dilemma question definitely answers that for sure, to kind of help. I think the other main thing that I found was trying to do a schedule for a patient. On our floors, we typically know when they will be getting meals. So just trying to help them give a little structure to their day really helped too. Because if you kind of think about it, what everyone's been seeing in the news, you're coming in a blue gown, a face shield. So people have no idea who's actually walking in the room. So like, as you've seen on TV, like putting the picture on your, so that way the patient can even recognize if you forget how much you miss when you really can't see someone looking at their gestures. I know most facilities, like we are still wearing masks, and that is a big thing with our nonverbals that we've had to really learn. And I can tell you, people are very hard of hearing. If you can't hear me normally, I'm a loud person, then you really can't hear me through the mask and face shield. So we've even had to learn how to adapt to really do the best OT we can with some of these new challenges that we faced.
I know when I think right now too, you learn how many people actually rely on lip reading to subsidize what they're missing.
The seniors, especially, But the seniors were a big thing with their little flip phones that they use, that we all know that they just want the just in case of emergency phone. But I had several that were here for a long time and got to know their spouses really well through FaceTime. Unfortunately, I had 2 that I had for a long time that had passed away. And I think, you know, I don't know what this next winter is going to be like, but, you know, one area I thought of, all these family members that were sitting outside. Right now, everybody's allowed to have 1 visitor in, but if we end up having to go back to no visitors, you know, some kind of support group for people that have family members that are in the hospital with this COVID is kind of something that's missing out there. You know, it's so new. And we were all just hustling and bustling and trying to figure out this new virus and how to handle it. You know, it was just such a big gap. These people sitting outside, I mean, literally sitting under a tree all day long in their car, praying around the hospital for their family member. And I would go out to talk to them in FaceTime, and the therapist would be at the window. You know, it just, the support group, maybe that, you know, people, is a big gap that probably, maybe we can address that if it hopefully won't get like it was again, where we can't have visitors in, but they say we are headed that way, but hopefully not.
I will say too, I think a challenging thing for a lot of our patients too, that were more aware just being on the COVID floor, is that constant fear. How is this going to affect me long term? And then too, when you're watching the news constantly, like I can't tell you how many times I just had to do education on, like, you have to take a break from that social media with seeing all the statistics and everything. Because literally some patients were like, I just don't want to die today. And that's really was their goal. So I think it's just kind of a balancing act with COVID being so new, and the things that we learned very quickly in March to even like some of our protocols now. So it'll be very interesting to see if we do have another wave, what will go into it, and how really our services are really that important. So,
yeah. I mean, I had one gentleman, he was a 60-year-old man. It was right after the state kind of opened up, and he went to a 4th of July cookout. He lived alone, ended up with COVID. He was in his early 60s, wonderful, sweet man, large man, obese, but diabetic, hypertension. I treated him. I gave him that, the home exercise, COVID home exercise program that's in the presentation. And we were doing all sorts of energy conservation. He was on about 2 or 3 liters. I remember I was gone for a few days, and I come back, and he was on one of our regular floors. He knew, I just don't want to go down to 2. I don't want to go down to 2, our ICU floor. And I said, no, you're doing great. And he was mobile. We were doing all sorts of ADLs and energy conservation and the arm exercise. He would prone. I come back a day or 2 later, and he was downstairs on the vent, and he ended up passing away. And I met his daughters. And it's just amazing how things could turn so quickly. I would have never thought that he would have deteriorated like that. I thought he would have been discharged home by the time I came back. I mean, that's how just unusual this was, how fast that you just go, wow, what medically happened to him? And that wasn't a good ending. It was a very sad situation. The daughters got to come in end of life. They did let people come in during end of life situations. So,
Dr. Shaw, will you unmute to tell me your question? I know you have.
Yeah, good job, guys. This is really interesting. So like, I don't understand the physiology of why proning works, because it would seem like it would restrict your expansion of your lungs or something.
you're actually, you don't want fluid. I mean, in a very simple way, when you're on the vent and you just say supine the whole time, the fluid just sits and sits and sits in the lower half, and it just gets worse and worse. So if you shift to your left side line, you're shifting that fluid around. You're trying to break it up. You're trying to get it out. They're trying to break it up so they can suction it out. Do the same thing proning. Shift the fluid. They're trying to break it up. They're trying to suction it out. Go to your right side, same thing. So we do that.
Oh, see, I think I'm so glad you explained that. And I assume they were just only laying prone.
No, you're shifting them every.
So you're just moving the fluid around. Okay.
So you're trying to break up that fluid, just
Yeah.
like when you get up in the morning,
Yeah.
all your fluid, if you have a cold, it shifts it and you cough when you first sit up, that kind of stuff. And it just, so it gets it broken up, and then the respiratory therapy, they can come in and suction it all out.
And even too, like our shot, well, with like the vibration, I know, like with the vibration vest they used to do here. So if you think if someone's on their stomach as a best example, they can go on, they can do more at the back and the buttocks, looking at that way to do that sensory stim also, that you wouldn't be able to if someone was ready on their back the whole time.
Right.
And I think visually, if you kind of have to see like what's going on with the anatomy of the lungs actually dropping down, you can physically see some of like how that would guide that fluid to be able to drain out. And it's just,
they're prone, but they're at a little bit of an angle also. And then they shift them this way, and then they shift them supine, and then they shift them to the other side. And when you first walk in, it is overwhelming when you see, especially in an obese patient, prone. I mean, you just go, oh my gosh, this person just, and they're totally sedated and paralyzed. It is very overwhelming to see it. But I mean, I heard it a lot all over the news and understood, and it really, really helped these folks. The quicker they get in there and prone them and get them keep switching positions, it helps them.
and that's why there's a different protocol. And that's where we had to really work as a team with our pulmonologists to help to really, they were the one that ultimately decide how long someone would be prone on each position of the body. Sometimes they did want that 12 hours so that way they can fully get the max benefits. A lot of times, especially when they were on the vent, they needed that long for the process to actually work. But we really did see there was a progression that they dropped in the hours that they might need. And I think sometimes, especially in the beginning, when you do have someone in the obese category, when you're looking at a 300-pound person, the coordination. So no, we wouldn't want to just keep someone on that side for an hour because they need that longer proning. So that also is a big variable as the size of that person too.
Yeah, it was, I mean, some of these folks that were so critically ill and intubated 20, 25 days. I mean, they are essentially a quad. That's how profoundly weak they are. Their arms, their legs, their trunk, their head control, they're like a quad when they are coming off the vent and we're able to get in there and really start working with. I mean, people just limp like a wet kitten. I mean, you just can't even raise your arm to itch your nose. I mean, they are just like a quad. A lot of them are. And that's why the length of recovery for these folks, like the one gentleman I was telling you about that came here, he was here for a long time, then he went to LTAC for a long time, then he went to acute rehab, and now he's back home. I mean, you're talking this whole time. He was one of the beginning ones at the beginning of March, and he's just now, home. So, I mean, you're talking 8 or 9 months here that this has taken from him, and he's the one with the severe shoulder limitations from the brachial plexus injuries.
Chaplain service, yes. So they
Yes.
actually had to bring in additional support.
Mhm.
And actually, what the chaplain would do a lot of times, specifically on the different floors, like they would also check in with the family. So how it kind of would start from like a spiritual kind of standpoint is the nurses had set times when they were doing shift change to talk to the family. What they did have to do is limited to one person in the family was the direct contact person. In certain situations, if it was like an elderly like spouse, they would also call a child to make sure that information is going correctly. So they would coordinate it. And I think you can kind of come up pretty quickly based on some of the questions that they have on the initial assessment to like determine religious preference. But yes, there was so much more support brought in that area alone. And I can also speak on not just the chaplain services, but the nurses really did a great job. I think sometimes you think quick in and out, but when you do have this PPE in there, you really develop this rapport. And I think those guys, even like ourselves, like when you have those hard conversations, like you did see in the news, like, you know, you are holding someone's hand. That's the only physical contact that person gets that day. And it's hard, like I said, the emotional standpoint, not to get emotional about with these people because you do have this sense of loyalty with them and you really hope they pull through. And also what Piedmont did do, they created a special email where people could send cards and words of encouragement. And then not only just for the staff, like the community was great giving us like positive feedback, thanking us. Because yeah, I think everyone with the COVID, we didn't know what to expect, even being frontline workers. Like, are we going home and exposing our family in that aspect? Like we had different staff members who moved out of their home because they did not want to expose, you know, their this or that. So, you know, we saw the dynamic not only with the psychology of our patients, but also our staff members too. And I do think it will be something, definitely the role of OT, we will be seeing the long-term effect of COVID. And then also, it'll be something very interesting to see the research that is published with this.
Yeah, there's a lot of great information. I went to one CEU class about the long-term effects of a long admission in ICU and the delirium and the support that these folks need long-term to recover.
Well, I was thinking the staff too. I
Oh,
mean, you have your
I've
own
had quite a few tears over.
post-traumatic stress
Yeah.
syndrome,
Oh, yeah.
right? It's like just
Yeah, I mean,
intense. It's intense.
yeah, I mean, we've had a great team here. I couldn't be prouder of our PTOT, speech, nursing, respiratory therapists, pulmonologists. I mean, initially it was like a war zone down there trying to figure out everything. And like I said, you know, a lot of people in the rehab world don't like to work in hospitals because of all the medical stuff and scared I'm going to kill somebody, you know, get them up and they, you know, have a PE or whatever. And, you know, I try to, like last year when we did this, I try to talk to the, you know, people that were there about there's just so much to learn in an acute care setting every single day. Every patient is different, of course, but just like in a rehab setting, but the medical stuff that you learn, and this year has been, you know, clearly obvious that what you learn medically about things that can happen with a patient and these strange new illness that can arise. So we have definitely learned a lot. We've grown together. We've shed a lot of tears, lost a lot of patients that we became very involved with. I had one young kid, his dad had died that evening, that morning. The mother woke up the next day with the symptoms. She got brought in. I just kept praying, please, please don't let this mother die. Please don't. This kid was my kid's age, 25 years old, and his dad had died one night and his mother was in the hospital the next day. And we were mobilizing her and doing everything we could. And unfortunately, she did not make it either. And so this poor young kid, a 25-year-old, lost his dad and his mom, you know, over COVID.
And I think too, like, it's just, I think the unknown factor was like the scariest. I know for me, with trying to, as someone who likes to plan and very literal, not having the information to even understand what we were dealing with. I think until you work firsthand with these patients, because in my mind, a healthy individual, how can they get that week in 48 hours? That is crazy. But then to truly see it and see the struggle, what these individuals had to overcome to do. And I think it's very interesting to see that, you know, we saw all pretty much from young to old and how they were affected. And I don't think there's any way you can say that not, I mean, honestly, I know at least a few people, all my friends have had family members with COVID. I think that's something that we will speak for my generation to COVID to come, just like very similar with like polio. So it will be something that will be talked about in the future quite a bit. I think the other thing I'm gonna say, like we had staff members, our outpatient therapists had to come into the hospital. They were not acute care trained therapists, but they jumped right in to help us because we were so thin at one point. Even as an OT going into the room, I was happy to strip the linens if I could, empty trash, just to help the other employees in the hospital, like our EVS. They were working their butts off to get these rooms clean, but to hear what everyone had to do just to clean one COVID room blew my mind completely.
What is that one?
Miss Pat, ESIM for muscle strengthening is not really used.
Yeah, I mean, I've been doing acute care a long time. No, I can't say that we use it very much. Even to my knowledge, I can't think of any time that we've ever used it. I do know when they leave here and go to acute rehab, of course, or to outpatient, yes. This is probably the first time we've had patients that have been in an acute care setting for long periods of time, because we essentially became their rehab. Most of our folks are in and out. Like we said, our goal is 4.2 days to get people in and out and back home or wherever their discharge plan is, the normal non-COVID patients. But these patients are the ones that stayed for a long time.
So going to your next part, Ms. Pat, about the profound muscle weakness, I would say, honestly, we do not have the resources in the hospital. I do know there is one TENS unit that the PT department has to kind of demonstrate to some of our chronic pain patients. I know sometimes they'll use it on the quadricep if it's a new like drop foot or something like that, but there's other goals those are working for, just not really weakness. So I wouldn't say we would have those resources of the units. Obviously, I've used it in the outpatient quite a bit, but directly for the ESIM unit, I wouldn't use it just for strengthening alone.
And then the COVID patients, the equipment was a big issue, what you could bring into the room and what you couldn't bring into the room. And then the wipes became an issue, and then what we had to use to clean the equipment. So it was just constant change. Every 6 hours, it would change from what we had to do in the morning to what the protocol was in the afternoon about what we couldn't bring into the room.
Yeah, even like as simple as like the vital machines, because at one point, typically when we have someone in the isolation rooms, they would have their own vital machine so we could take vitals. We got to at one point those had to be carefully covered so they could go to rooms. So that's why I can honestly say Piedmont did a great job trying to separate the COVID floors from the non-COVID, even as well as making sure there's a direct access from our surgical floor up to the patient's room, all went into consideration. So from a management standpoint, it's been very interesting to learn what all goes into it when you're kind of dealing with a new situation like COVID.
She said for our COVID patients, even in the rehab, we didn't use the stimulus.
Yeah, initially our rehab, we didn't use the telemetry units with our COVID patients just because of the interference with the telemetry. So it wasn't until we knew the patients were more stable and we were for us, they were much less acute than what you're describing for COVID patients. So we were able to get them in the shower and things of that nature that obviously we're taking off their telemetry for anyways. But all of those things kind of will hinder the use of eSTIM and some of those other modalities you want to use.
Right.
And I think too, it's been kind of interesting because I've talked to fellow OTs and even PTs that I know at different hospitals, even finding out what their protocols were when COVID first started and how they adapted has been kind of interesting. And I think it's something that, we do have some of these set protocols now, like with our event parameters, but, we've had to adapt and find that it's still okay because you talked about, for me, knowing the protocol typically with that high flow, we're not supposed to mobilize them at that point, but then getting the all clear from the physician, you better believe I wanted the respiratory therapist right there with that okay that I could have them moving. So I think it's really that learning curve. And I definitely learned that it's definitely the communication between, and I can honestly say the relationship with those staffs completely with the medical doctors are very open with our suggestions. And that was really my takeaway from the whole situation too.
Yeah.
So
The energy conservation, I would love to see some of these patients that left our facility and recovered and are at home. I'd love to talk to them and see them and see how they're doing with their activity tolerance at this point. It would
Sounds
be
like a great case study.
it does. I mean, just that OT part of it, the energy conservation with ADLs and higher level ADLs and how many went back to work or had the endurance to go grocery shopping, that kind of stuff after this illness. I mean, it's just so much to learn still from this.
Now, I know you didn't mention it in this presentation, but I was curious if you had any thoughts on ECMO or if anyone at your hospital is really talking about moving in that direction, or do you have those, do you have that capacity at this point? Or
We get a lot of, we don't have it at Piedmont Fayette. They transfer to Piedmont Atlanta for ECMO and then they come back. We had the one family I was telling you about, the 25-year-old gentleman where his father passed away and his mother came in, and we actually got her up quickly on the vent and she was doing well, and then she deteriorated, had to go to Atlanta. ECMO came back to us. I thought, okay, good, she's still here. She's gonna, we can start working with her again, and she just deteriorated again. So we did have a lot. I can't even remember how many, but we had a good bit that would go to transfer to Atlanta, do the ECMO, and then come back to us once they were stabilized from that and came back.
do you, I don't know how many people, I know at our facility when we started talking about ECMO, people weren't really familiar. Do you want to explain it for, maybe I'm the only one that had that experience, but did you want to kind of talk about the benefits or just kind of what it is in general?
Here we go.
Yeah.
Yes. Yeah.
And I think, I love the parallel that you made earlier for our generation. This will be like polio, because when you think of the iron lung and how antiquated that is, it makes me wonder, is this the direction we're going to move in general? Because the machines are quite expensive. So it's, to your point, I haven't had the benefit of working with one, but it's usually, they're kind of, not everybody has access. They were invented relatively recently. But they seem to have, we don't quite understand, the damage we do at a cellular level to the lungs with long-term ventilation.
Mm-hmm.
And we don't see that same type of thing with ECMO at this time, but we don't have as much longitudinal research on it, I understand. But yeah.
But we are thankful when we see people come back from being on ECMO and come back. Unfortunately, she was did not end up making it, and that was the gentleman I was talking about, lost both his parents. And I had a couple phone calls with him when I was talking to him when she was getting up with us. He was so excited, please do anything to save my mom. His dad had just died, so unfortunately she did not. And I think about him because he's the same kids at my kids' age. So yeah.
Mm-hmm.
But I call it the super vent. Yeah.
That is a great way to describe it, though. It certainly is.
Yeah. Anything else? Nope, that's it.
So I do know the PowerPoint, Tiffany is going to have those available if anyone would like it, with also the resources and our contact information's on there. And then the other key thing is make sure you fill out your survey so you can get the CU credit. We're supposed to tell everyone that.
Oh, yes. And come work in acute care. You'll learn a lot.
Thank y'all all for attending.
Bye. Thank you.
Yeah, thank you. It was a wonderful session.
Yeah. Thanks, y'all. Bye. Bye-bye.